The typical standard in this country is to use RVD as treatment for multiple myeloma. Really, in my mind, there's only one other potential option for somebody like this, which would be using carfilzomib, lenalidomide, and dexamethasone. That regimen has shown good results in a phase 2 trial. It's not been compared head-to-head, but there's the potential, and I think it's certainly possible it'll work better than the VRD regimen. It's not always approved, however, by insurance companies to use. So if the patient had had favorable cytogenetics, I still would have recommended the same regimen. I typically use a triplet regimen for the majority of patients with multiple myeloma, so a proteasome inhibitor, an immune modulating drug, and the corticosteroids, because I think using all three weapons tends to work better and has been shown in a randomized trial run by Dr. Jury to improve progression-free and even overall survival. So I think it's really the standard. I will occasionally use an all-oral regimen and not give the bortezomib purely for convenience for some patients who seem to have a very slowly growing disease. And particularly for those patients who I'm not very worried about the pace of their malignancy, and they really have a hard time coming to get treatment. So as a first step, but I don't think it's preferable for most. The patient had a very good partial response to treatment. I know patients typically hope for a complete response, and that's always better. I think pretty much for any malignancy, it's better to be in a complete remission over a less than complete remission. But the reality is one has to decide what to do with a patient who's not achieved a complete remission. So for her, I think a very good partial response was fine. And I've had patients more than 15 years who've never relapsed once and who never achieved a complete remission. So it doesn't preclude good outcomes, and you certainly don't need to be in a complete remission before doing something like a stem cell transplant. Often the transplant is the only way of achieving a remission. One thing to remember for multiple myeloma patients is that you have to not only kill the cancer cells, but you have to prevent some of the complications that multiple myeloma can cause. One of the important complications is damaging of the bones. So patients should get some type of bone protective agent. Nowadays, there's really two choices, the zoledronic acid or denosumab. Both have been shown to be effective. There's advantages to some, one over the other, but I think for sure patients should receive some type of bone protective drug, even if they don't have bone lesions, which is not always apparent. Patients with multiple myeloma frequently die of complications from the therapy or really the disease, so infections. And so patients need to be made aware that they have to call in if they get sick so they can be treated quickly and to try to minimize the risk of dying from some terrible infection.